Yes, I pressed the button.
Okay, yeah. So I think we are on time, so we'll go ahead and get started. Good evening, everyone, and welcome to the Symposium of Public Health Equity Fellowship 2021-2022. So this has been a year-long research fellowship where 11 of the fellows who have been participating throughout, they participated in the research work, engagement, team meetings, group activity, and also sometimes listening to like the different speakers who had to talk about their own research, and they also talked about their own research and own findings about like particular topics too. So some of the people like and some of the entities I like to thank, because without their effort and participation this fellowship wouldn't have been possible. This is our second year running the fellowship, and when I'm saying we, that means there are people who have been helping and kind of instrumental in this process in past couple of years. So I'd like to mention a couple of those names. So for example, Dr. John Manch, who is also on the call now. Previously, he was the department head of biomedical sciences. Now he is in Medical College of Wisconsin. And we together actually started the initiative. Then I'd like to mention Dr. Joseph Binonabe, who is also from biomedical science, in short, Dr. B, who is overseeing our public health equity minor and master's program jointly offered from MCW. Then Professor Joshua Knox from Physician Assistant Studies, who has been instrumental offering the capstone and teaching the capstone courses for the equity minor students. Then Dr. Alexander Martin from Theology Department and also from College of Nursing. He is instrumental from the very beginning in different aspects. And then Dr. Sandra Hunter from Physical Therapy and Exercise Sciences. She is also the director of our HPRC center here. So all of these people have been instrumental not only in the fellowship, but the overall public health equity initiative that we have been having on campus. Some of the other people I definitely like to mention Dr. Jean Hosenlu, who is our current vice president for research and innovation at Marquette University. She has been supportive throughout the process from the very beginning, and she is very generous to promote the Public Health Equity Fellowship, the fellows, mentors, and their activity on her website and promoting it in via different avenue. And then also I like to mention Dr. Andrea Snyder, who is the current director of our Institute for Women Leadership, and and along with her, some of the other people from Institute of Women Leadership who has been very instrumental helping our fellows are Dr. Jenica Webster, Dr. Carly Surface, and they have been helping us throughout the process, and they have been supporting 5 of our current fellows, and they have promoted those fellows in their own gala program and through different avenues that IWL can possibly be. So with all that being said, I like to hand the mic to Professor Joshua Knox from Physician Assistant Studies to say a few remarks about like the mentors and the fellows. So Professor Knox.
Yeah, thanks. Thanks, Neil. Sorry I got locked out for the first couple of minutes, but yeah, so I'm very excited to be a part of this, a small part of this group. Obviously, Neil and all the mentors play a much larger role, but Neil and myself and Dr. Hunter, Drs. Manch and Bianaby, as well as Martins, have all been involved in this collaboration with trying to pull public health and equity education forward at the university for the last several years. Super excited about all the, you know, how many mentors have been engaged. 9 total mentors across 3 different colleges, and including 4 professional programs, if I'm not incorrect. There's really been excellent mentorship for the students. Students have learned valuable research skills. They've developed, equally importantly, they've developed important networks with not only individual scholars and researchers at Marquette, but at MCW and other organizations. Because Dr. Hassanlap, the Vice President for Research and Innovation, can't be available today, I was wondering whether I think it would be more powerful if one of the mentors was willing to talk, or one of the mentees for that matter, about their experience during the fellowship. Yeah, Jordan.
Yeah, I can talk a little about the experience overall. There were a lot of like moving parts to it, which I think is like what made it unique from like other experiences that we've had. Like every couple weeks we would get to meet with like a professional from like the public health realm or something related to it, and they would kind of get to guide us through what they were specifically working on. So we weren't just like laser focused, limited to just our ideas of like what we were going through. So that was like a big part of what we did with each other. But then we also had the opportunity to kind of break off and work not just with individual mentors, but also with different research groups that our mentors were like helpful in facilitating and having us like integrate into, which I think gave a like multifaceted perspective of what was available to us, what research looks like from different perspectives, both as like a newcomer versus someone who you could tell this was their billionth project putting together. So I think it was a great experience from the mentee perspective.
That's great. Thank you for sharing. Was there any mentor that wanted to talk about their experience?
Yeah, I can, Josh. Sandra Hunter here. You know, one of my mentees, Emily Anderson, I've really seen her grow, and I've seen, and it was a pleasure to speak to the students along with one of my colleagues about, you know, COVID and some of the disparities there and how it affects different groups differently. But in doing this, I really wanted to give a huge shout out to Neil, Dr. Lode, who just has taken most of this on his shoulders, and just to thank him profusely. If there was no Neil, there would be no Public Health Equities Fellowship. It just wouldn't be here. And he's really, you know, been a true leader here. So I just wanted to acknowledge him. I've seen growth in the opportunities that he's really provided and pushed forward with. So thanks, Neil. Really appreciate it.
Yes, absolutely. Did you want to transition, Dr. Lode, to the keynote?
Yeah, I think we can move forward with our first keynote speaker. So I'd like to introduce our first keynote speaker, Dr. Andrea Snyder, who is our current director for the Institute for Women Leadership on campus. And she has been a professor of law and has been teaching dispute resolution, negotiation, ethics, international conflict resolution for over 25 years at Marquette. And she received her AB cum laude from Princeton University and then JD cum laude from Harvard Law School. But the sad thing is that Dr. Snyder is kind of leaving Marquette, and from July 2022, she will be joining Cardozo Law School in New York as the director of the Curie program for conflict resolution. So we are very sad to see you go. And the work that you have been doing on campus and you have done so far is like very tremendous. I don't think there's much, we don't have enough time to discuss about that. But I just want to say one thing, what Sandra mentioned, like when we were discussing like your departure from university, then Sandra said like, yeah, she is a true firecracker. So we are going to lose that energy and the enthusiasm in the room when those discussion actually happens. So without further ado, I'd like to give the stage to Dr. Snyder.
Thank you, Neil. That's very gracious of you. And I promise to try to continue to help to launch grenades from across the states. Whatever you guys need is fine with me. IWL will be left in outstanding hands. And I know that, anyway, there's more firecracking to be done. So thank you for that. And thank you for having me tonight. I'm really honored to join you and give some very brief remarks. When you hear keynote, you think of like an hour long, and I want to be, no, just a few seconds here to just congratulate everybody. As Neil already hinted out, the Institute for Women's Leadership at Marquette was created to advance women's leadership locally and globally through pioneering research, programming, and collaborative engagement. And this vision of research is something that is absolutely exhibited here. We are trying to create this interdisciplinary, vibrant research community, an environment that equitably and inclusively supports our faculty and students as they engage in impactful and transformative scholarship. And your work tonight, I've already had the pleasure of seeing pieces of this at our own presentations at IWL, and your work that all of you have worked on this year is really doing that. We have ongoing challenges in our world. Peace and democracy is not to be assumed, even in the United States, as we know, and the push for racial, religious, gender equity continues to face backlash, in which even, frankly, elementary school math textbooks can be banned. Ideas that push us to think are seen as too dangerous to even learn and talk about in a classroom. As a young woman, I repeatedly read the biography of Marie Curie, who overcame numerous obstacles in her pursuit of science. And as she noted then, nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. And I think this could equally apply today. Your work that all 11 of you are doing with your mentors helps us understand more and fear both equity and science less. Congratulations on your accomplishments and a terrific year. I am looking forward to learning more from you now and into the future. Go forth and get them. Be your own firecrackers, and congratulations.
Thank you very much, Dr. Snyder. Very well said. So I'll probably go ahead if Dr. Kim Whitmore is here. Okay, so I don't think Dr. Whitmore is on the call. So I can go ahead and introduce our next speaker. So our next speaker is Dr. Kirsten Johnson, who is the current Commissioner of Health at the City of Milwaukee Health Department. And I had the opportunity to meet with Dr. Johnson in my class this semester, and students really loved the talk and the way that she delivered and kind of the engagement that she is doing, because she came into the department at a very troubling time, because as a public health researcher, I know that pretty well, but she handled and managed it really well and moving it to a very good kind of public health 4.0 in that like new direction, like what is needed. So just to give you a little bit of background about Dr. Johnson, in 2018 and 19, she was a Robert Wood Johnson Foundation Health Policy Fellow, and she served as a health policy advisor for Representative Ron Kind in the US House of Representatives. And there she worked on different types of bills to stabilize Affordable Care Act, broaden the FMLA, address health inequities, including maternal mortality, increase Medicare access for organ donors and recipients. So different things of work. And as a Commissioner of Health, she is leading the pandemic response in City of Milwaukee, as regard like we are still very much in the pandemic. And she has been working diligently to rebuild the foundation of the health department. And her instrumental work, which was the first in the country as an officer in the Washington and Ozaukee County, she recognized for her leadership, and she kind of merged both of these health departments together and make it one. So I don't know like how that she did, but she actually instrumented that. So without further ado, Dr. Johnson, the floor is yours.
Thank you very much, and thank you for having me. Kirsten Johnson, I'm the Commissioner of Health for the City of Milwaukee, so thank you for the great introduction. I want to start by saying congratulations to all of you, all of the fellows, for I'm sure a really fascinating and a tremendous year of growth. And I understand personally the value of being a fellow. And I just want to say to you, from a fellow to a fellow, and really support and recognize how important your fellow fellows are, frankly, and the network that you build through your fellowship, how just really value it, and make sure that you lean into it as you move through your academic career and into your professional career, because those relationships and the people you meet, you'll be remembered, and utilize it to really do the best you can for the communities you work in. So, just as you all are well aware, it's been an unprecedented time in public health over the past 2 years, and we have such a significant need for the public health workforce to be filled with people who are critical thinkers, who know and think about public health broadly, who understand the importance of public health, but also how critical it is to think about health equity and what that means for us as a profession, and how do we advance and really make a difference to assure that everyone has access to healthy outcomes and healthy lives. So I know you've learned a tremendous amount over the course of this year, but I encourage you to take what you've learned and run with it. Governor Evers recently just published a health equity executive summary that I hope, if you haven't seen it through your coursework and through this experience, but that you should go out and look for it. I believe it was just published in the last couple of days. So I encourage you to look at it, because I think it's really a sort of a sentinel document that outlines what we need to do in Wisconsin specifically to advance health equity in all of our communities. And so certainly something you could dig into and look at as you further your academic careers and your personal and professional careers as well. So we've learned a tremendous amount over the pandemic. Dr. Hunter mentioned this sort of in her comments, but that really the social and economic conditions that existed well before the pandemic really created and further highlighted the disparities we're experiencing in health throughout the city of Milwaukee. And I think those of us who've been in the response mode for the last 2 years deeply understand, and this is it's really illustrated health equity and health inequity, and really put sort of a fine point on it. But early on in the pandemic, the people who were most impacted, who didn't have, who were working multiple jobs to bring food home to their families, were the very ones who were getting sick, and really couldn't stay home because they were working multiple jobs. They didn't have paid time off. They didn't have sick or vacation time, and they were working multiple jobs because they weren't making a living wage. And I think all of those things that I just mentioned are policy solutions that we and you as new leaders coming into public health really need to think about. How do we advance some of this agenda, both at the local and federal level, to assure that if there is, and when and if there is another pandemic, we are not faced with with the very same significant disparities that we've experienced. And so all those things I just mentioned as well really are those social determinants of health, which I'm sure you're all very well familiar with and well versed in now after your fellowship. But again, the social determinants of health are really what drive the work of public health. I'm not sure if all of you are familiar with the concept of public health 3.0, but that's the idea that health departments and people working in public health serve as chief health strategists for their communities. And how I envision that, and what I'm trying to bring to the city of Milwaukee, is that chief health strategist lens. So again, those policies I just mentioned, that we are advocates in advancing some of those ideas. But I'd even argue that we need to take it one step further, and that's public health 4.0, which I did introduce in Neil's class when I spoke. But public health 4.0 is really the ability to be a critical thinker and be agile and nimble, which we've never been great at in governmental public health. But with you, all of you as new leaders, and all of you with the relationships and the network you've built over the course of last year, that's my sort of message to you: is come forth into public health. It's a tremendous opportunity for a really rewarding career, and also use the science and research you've known to be a critical thinker, and recognize how important it is to be agile and nimble. And you as young people have that opportunity. So thank you. Thanks for having me and congratulations.
Thank you very much, Dr. Johnson. So we will move on with our presentations. So Dr. Martin, Dr. B, and Dr. Hunter will be introducing our fellows and their topics, and Ms. Amanda Zastro will be controlling all the presentation from the background. So without further ado, Amanda, you can pull up the first presentation, and I want to give the floor to Dr. Martin.
Thank you, Neil. Thank you all for coming, and a special thank you for all the students and who engage in that research, and for all mentors who guide the mentee throughout the year during that health equity fellowship. So I'm Alexander Martins. I'm assistant professor at College of Nursing and the Theology Department. This year I had not been very actually engaged with the fellowship because I'm in a sabbatical. So just from my research cave, I have dedicated all my time and be here happy to see all the accomplishment of our students and support them as have been supported for the entire year during the fellowship. In the first presentation, you'll be led by June Young. She's a graduate student and doctor in a graduate student in the doctorate program in physical therapy. She works with Dr. Daniel Pinto, also a professor of physical therapy at the College of Health Science. So June Young, you have 5 minutes to present your project to us. Thank you.
Thank you for your introduction. Hi, everyone. My name is June. I'm a Doctor of Physical Therapy student from Marquette University. So today I'm very happy to present my research work on Build Better Bones, representing Dr. Pinto's Beta Lab. This is a project we collaborated with the International Osteoporosis Foundation, and I would just like to give an overview of what osteoporosis is. It is defined as a skeletal disorder, or really it is characterized by a reduction in strength of our bones. So as we age, bones become less dense, they weaken and are more likely to break. This is very common to have over the age of 50. So it's a serious and a costly problem that can be preventable. It's a little bit tricky though, because most people don't know they have it. And osteoporosis is a silent disease, and we can't see or feel that our bones are weakening. Now, COVID put in a sedentary lifestyle in many people that further increased the risk of developing this disease, and our senior populations are especially vulnerable. And as a team, we want to investigate to see if we can provide a remote resource to enhance the rehabilitation experience. So all things considered, we created a beta version of the website, teaming up with the rehabilitation working group of the organization. We have animators working on the website and a third-party web designer to help us complete this vision together. So we like to see what people think of it. So if Amanda, you can turn on the next slide. We created 2 surveys, one for the users and more so our patient population, the other one for our providers. We collected information like the demographics, and we utilized system usability scale, which is just to assess the quality of our website. And we have opinion questions about the website features, including the exercise animations, the blog posts, and the health content. So a picture is worth 1,000 words. So on the left upper corner is a QR code that we created. If you scan it through your phone, you can access to our survey, and that includes a link to our website. So right in the middle is the front page of our website called Build Better Bones. So let's see what the survey says. So Amanda, if you can turn on the next slide. So the survey says that the providers agree that they would like to use the website as a resource for the patients. The website is well integrated and easy to navigate, but there are things that we can make it better, such as we need to add more safety tips to our exercises that include more high intensity exercise and have more recommendations on outdoor exercise such as walking and running. And perhaps we can add more images of younger people. So, yeah, okay. So I think our team has done a great job on the website, but there's limitations within our survey that we're a little bit overly strict on the inclusion criteria. Instead of asking, are you someone who has osteoporosis, we should have said, are you someone at risk of osteoporosis? Because that excluded 70% of our potential users. So that's something that can easily change. And then another thing is that we need to widely distribute our surveys to more like local, older adults communities. So to summarize things, so we created a website and we created the surveys. We received feedback on how we can improve the beta version of the Build Better Bones, including making it more acceptable to younger and more active patients. And we can add more, we can do better by adding more safety tips to how to do these exercises at home. So the whole purpose of this project is to get the senior population engaged again and provide the resource that they need to find confidence to participate in the activities that they like. And we don't want to leave anyone behind. So that's the key things that we want to get. So that concludes my presentations. And if you have any questions, I'd like to answer them.
Thank you very much, Jun Young, for your presentation. Now we move to the presentation of the Navid Kaur. He's a bachelor's student at the College of Health Science, doing his BS in biomedical science, and he worked this year with Dr. Lodge in the project related to determination of health and well-being of Afro-American communities in Milwaukee North Side in the via assessment of telehealth and health monitoring intervention. Navid Kaur, so the floor is yours. We have 5 minutes.
Thank you so much for the introduction. Hi, everyone. My name is Navneet Kaur. I am currently a junior majoring in biomedical sciences and minoring in public health and equity. Today, I'm going to talk about my work that I did with Dr. Nilanjan related to the health and well-being of African American communities in Milwaukee's North Side via assessment of telehealth and other health monitoring interventions. For the introduction, recent research has highlighted the importance of telehealth in improving the health of patients during COVID-19 pandemic. Many healthcare systems are turning to telehealth because of the pandemic, and there have been signs of new technology being vital to the health of many patients. Further research on access of telehealth is necessary due to the health concerns like asthma and hypertension faced by patients, especially in Milwaukee. This project will be focusing on people living in Lindsley Heights on the north side in Milwaukee, and will assess the telehealth and how it can improve the health disparities faced by African American communities. Why we chose the city, as we all know, it is one of the most racially and socioeconomically segregated cities. For materials and methods, we started off by reading and analyzing research article reviews. Next, I created a logic model, which is also known as the Presidential Challenge Grant Objectives and Beyond, which we will talk about later in the slides. And then we found glucose monitor, which we will be giving out to the participants in the pilot study. We did a review article manuscript, which I will show in next slides, and finding the journal guidelines. We also did analyze the retrospective data that was collected from Bread of Healing Clinic, and we had 2 community health forums at North Division High School in Milwaukee. Here's the logic model. It summarizes the roles and objectives of all the organizations, clinics, churches involved in our research. For example, Marquette University is the frontline workers like students and professors. With WWCC, Lindsley Heights communities, their importance is to determine the need of community and access the scientific research and expertise. With the 10 churches, they're helping us recruit participants for our pilot study. For Bread of Health Cleaning is from where we did the analysis of the retrospective data. On the left side, we can see the glucose monitor that we will be giving out to the participants of our pilot study. And on the right side is a picture of the review article manuscript that we worked on. Moving on to the results, this data right here shows the prevalence of diabetes, hypertension, and asthma in different age groups. If you see on the bottom, with different colors represent the age group, like the blue represents age group around 13 to 35, green more like 36, 50, darker green is like 51 to 16, and then red from 60 and over. On the top, on the x-axis on the top is hypertension, y-axis on the right is asthma and COPD, and on the left of the y-axis is diabetes. As you can see, those little small boxes saying yes and no. Yes means they have it, no, they don't. We can talk about the bottom box on the right side in the corner. We can see where all of them are yeses, so yes to the hypertension, asthma, and diabetes. We can see that it is more prevalent in age group 51 to 60 years old and 61 to 86 years old. As expected, it's more in elderlies. For my conclusion, our research on telehealth and its importance will help inform the community, its advantages, and how to better utilize telehealth to treat people living in Lindsley Heights and neighborhood. For our future goal, we hope to work on multi-year comprehensive data analysis, pilot study while monitoring devices like glucose during the summer, and we also hope to have our third community forum via Teams. We did the other two in person, and we hope to do the public and scholarly dissemination of our data. Here's your picture from Community Forum 1 and then Community Forum 2 that we had on the right side. On the left side, you can see like the bottom picture. We also invited different vendors in Milwaukee to support their business and organizations. And at last, I would like to acknowledge the Marquette University Presidential Challenge, WWC, Bread of Healing Clinic, local churches, and Mickey and the other fellows involved in the project. And thank you so much.
Thank you very much, Navni Kaur, for your great presentation and your work. Next, we have Emily Anderson. She's an undergraduate student in exercise physiology, and she's here under the mentorship of Dr. Sandra Hunter on the project of persistent and long-term effect of COVID and physical functions. So thank you, Emily, for your presentation, and you have the floor.
Thank you, Dr. Martins, for that introduction. Again, I'm Emily, and I worked with Dr. Sandra Hunter on the COVID-19 survivor study, looking at the lasting effects of COVID, and we did so in the Athletic and Human Performance Research Center here at Marquette. So just a little introduction about COVID. So what is COVID-19? It's an infection that's caused by the SARS-CoV-2 virus, which is a photo of it right here. And as of April 27th, according to the CDC, there's been a total of over 81 million cases of COVID-19 that have been reported just in the United States. So some of the symptoms that appear with COVID are fatigue, fever, shortness of breath, body aches and muscle aches, cough, and then new loss of taste or smell. And so COVID can present itself a little bit differently among individuals, and we have seen this through the various variants of COVID, but COVID often differs in terms of duration and severity of symptoms. So it can be categorized as the acute infection versus the long COVID infection. or developing into long COVID. So the acute infection is in regards to the symptoms that I mentioned on the previous slide. And then long COVID refers to lingering symptoms after recovery from the initial acute bout of illness. And it's important to note that not everyone that gets infected with the SARS-CoV-2 virus will develop long COVID-19. So it's very individualized. You can move to the next slide. Thank you. So what's the point of studying patients who have had COVID-19? As we all know, it's a very prominent issue in our society, and it's still ongoing and evolving. As of May 1st, 2020, there's been over 80 million cases and over 990,000 deaths within the United States, according to the CDC. And according to a paper from Groff et al., over 50% of the people who have contracted COVID-19 still have lingering symptoms. So some of the aims that we have from this study are to understand the persistent effects of long COVID in terms of physical function, as well as to see if there are any sex differences in the presence of long COVID-19, and how women may be more impacted by COVID-19, as well as a better understanding will help us be able to treat COVID-19 in the future in forms of best practice for rehabilitation. So a little bit about our methods of our study. So as of April 27th, we have tested 115 subjects at the AHPRC. And so we've had 78 COVID survivors come in, 37 control subjects, and then we have control matched 36 of the COVID survivors with 36 controls, and they've been matched for height, weight, sex, age, race, and ethnicity. And then a little bit about our criteria for testing. So they have to be at least 2 months out after that initial bout of infection. So theoretically, they should be recovered by then so that we can assess the persistent effects of COVID. And then our subjects will come in for a one-time testing session at the AHPRC for about 3 to 4 hours, where we run them through a whole battery of tests, including vital signs like height, weight, heart rate, various body composition measures of muscle mass and body fat percent, different cognitive and fatigue questionnaires, as well as pressure, pain, threshold assessments, hand grip strength, balance assessments, taste and smell assessments, and a breathing and aerobic fitness test, as you can see from the photo. And then a little bit about our results. So this is not a comprehensive review of our results. There's a lot of information and variables that we are dealing with in our study, but these are just the ones, these are just a select few. So on the bottom right, or the bottom left-hand corner, is a chart of the most common symptoms of COVID in terms of initial symptoms and persistent symptoms. The top left-hand side is shows the difference between the loss of taste in males and females, and it was significant for female COVID survivors. The purple bars are COVID survivors, and blue are people who haven't had COVID, as well as the significant difference in female COVID survivors in terms of increased pain levels and increased levels of fatigue. So why does this matter at the end of the day? There are considerable persistent effects of COVID-19 that impact activities of daily living as well as quality of life for an increasing number of people, and this is affecting even healthy individuals, as most of our subject pool is on average 7 to 8 months out post initial infection and are relatively young and healthy, as well as we still don't know how to treat COVID-19, and we're starting to understand some of the persistent symptoms. So as far as next steps, we're going to be partnering with the United Community Center to bring our study out into underrepresented individuals who are more affected by COVID in terms of rate of infection, deaths, hospitalizations, as well as access to resources, and apply for NIH grant funding in the future. And that's it. Thank you. If anyone has any questions, you can let me know.
Thank you very much, Emily. Wonderful. Next, we have Radhika Dua. She's an undergrad student biomedical science and also a accelerated master in science student in global health and equity through Medical College, Wisconsin. She has been working this year in the fellowship with Dr. Elizabeth Angeli and Dr. Nilajan Lott on the role of rhetoric in medicine, the role that rhetoric in medicine plays in healthcare, especially in emergency medicine and care. Radhika Dua, thank you for your work, and you have the 5 minutes to present your project.
Thank you, Dr. Martins, for that introduction. I'm Radhika, and this year I have the honor and privilege to work with Dr. Angeli and Dr. Lowe on my research on emergency medical services and the training they receive in identifying human trafficking. Next slide, please. So what is human trafficking? Human trafficking involves the use of force, fraud, or coercion to obtain some type of labor or commercial sex act. There's no defining characteristic of survivors of human trafficking, but traffickers often prey on people who are young, vulnerable, or in need of something. Traffickers may be someone an individual knows, such as family members or a friend. A study was released in 2020 where 340 individuals were identified through Milwaukee Police Department records as victims of sex trafficking in Milwaukee between January 1st and 2013 and December 31st, 2016. This map to the right is from that study, and it shows a visual representation of where incidents of human trafficking took place in Milwaukee, with the dark red being high incidence of trafficking, with the highest being in zip codes 53204 and 53207, which is also where the Milwaukee airport is located. This really illustrates that human trafficking is a very prevalent issue in Milwaukee that often goes unnoticed to the extreme that about 28% to 50% of trafficking victims in the United States encountered healthcare professionals while in situations of human trafficking, but were not identified nor recognized. This all led to my research question: are healthcare professionals trained to identify situations of human trafficking, and how confident are they in implementing their training? Next slide, please. To do this, we sent out an online survey to emergency medical services, which included, but wasn't limited to, EMTs, firefighters, first responders, nurses, PAs, and doctors. The survey was modeled and adapted from the Katanza study. The anonymous survey asked providers to rate their confidence level in being able to define human trafficking, the resources providers currently use, and their knowledge in non-medical resources that they, as providers, know and are able to give. They were also asked to rate their level of agreement on statements, such as if they have tools such as training or screening surveys that accurately identify situations of trafficking. The survey focused to answer, what does current training focus on for healthcare professionals in terms of recognizing human trafficking? And do healthcare professionals feel confident after their training in identifying situations of human trafficking? Next slide, please. So these results show that 50% of these individuals of EMS providers who took the questionnaire had received training. 66.7% of these individuals felt hesitant in being able to effectively communicate with a patient suspected of being a trafficked person, and 33.3% felt hesitant in knowing how to refer individuals to non-medical resources. Next slide, please. 77.7% of EMS providers feel as if they don't have the accurate tools or resources to provide care and help. And 88.9% of emergency medical service providers strongly agree that they need to be more training pertaining to human trafficking. Next slide, please. So, conclusions. The current findings really show that EMS providers feel as though there should be more training available, especially because emergency medical service providers are usually one of the first healthcare professionals an individual who's being trafficked might encounter. As with COVID-19, situations of trafficking can be harder to identify, as stay-at-home policies and school and work closures can prevent individuals from having a safe space from exploitive situations. Recommendations such as more trauma-informed training and informing healthcare professionals of non-medical resources such as housing, shelters, and food assistance programs can work to help an individual. As providers, being able to communicate and effectively present both medical and non-medical resources is essential in giving a holistic care for a patient. As for future findings, I hope to continue this research as we're still receiving responses from the survey, and I hope to continue educating myself and others about human trafficking in Milwaukee. This really serves as a reminder that human trafficking is a public health issue that is highly prevalent in Milwaukee. Next slide, please. Next slide. I'd also really like to thank and acknowledge everyone who supported me throughout this fellowship. Thank you so much.
Thank you very much, Radhika Dua, for your wonderful presentation. All of you make my job very easy here. Everybody being presenting very professionally on time. Now I will pass the baton to my colleague, Dr. B, who will introduce the next students.
Thank you, Dr. Martin, for the great job, and thank you, the presenters. I have the privilege to provide you with the next set of 4 presenters who have been working closely in the Public Health and Equity Fellowship. My name is Dr. Biononebi Joseph. People call me Dr. B. So our next presenter is Kirsten Hatfield, as former who is studying criminology and law and has been working with Dr. Alexandra Snowden. So please, the floor is yours, please.
Thank you. Hello, everybody. My name is Kirsten Hartsfield, and I've been working with Dr. Snowden over the last year with a study focused on community-level correlates of health disparities. Next slide, please. So to do that, I was tasked with creating a literature review with the objective to investigate and review existing literature on the causes and correlates of health disparities in communities, particularly with COVID-19 and minority communities. Next slide, please. So to start, Dr. Snowden gave me a few research articles that had already been published that kind of fit into this theme. And from there, I used keywords like community and environment to search for more research articles that fit into the theme. With each article I found then, I created one-page summaries and split them up into the categories of the main objective, background, method, and then results and conclusions of the studies. And from there, I made connections on kind of how I wanted to split things up in my literature review. So articles either focusing on environmental factors in community or health factors and generally just more COVID-19s explicitly. Next slide, please. So the factors I really talked about in my literature review then and that were really prevalent are the ones listed on the screen. And I'll touch on each of them a little bit and how they're related to health correlates in communities. So built environment was a big one. One article actually stated that 99.9% of death causes were explained by built and social environment predictors. So obviously it's a pretty prevalent role in health and communities. Things that would fall under this category are building design, air quality, and housing conditions. And to get a little bit more specific, crowded housing is like linked to higher risk for health, and street connectivity is linked to lower risk of health issues. Also, additionally, mixed land use, so having residential and employment buildings, not just one or the other, is linked to a decrease in health risks. It was also discussed, transportation was also discussed between active and sedentary transportation in communities. So biking and walking are obviously more active and lead to healthier lifestyles, while sedentary areas that have more auto accessibility lead to increased risk of health problems. Employment included things like essential workers and low-wage employment workers having an increased risk for health. And connected to built environment, kind of, the more essential workers living together was found to increase chances of receiving communicable diseases such as COVID-19 and other health factors. And then another big issue within these communities was socioeconomic and sociodemographic statuses. So low income, high deprivation, high neighborhood hardships equated to higher health risks compared to high income neighborhoods where there was lower health risk. And race was not really ever mentioned, but social and economic disparities tend to be connected with race in most of these research articles. Racial and ethnic minorities were said to live in high deprivation areas more frequently, which then equated to them being more at risk for these health problems. And then just to touch on the age and previous health conditions, those were some big factors that were listed more frequently for COVID-19 specifically. Next slide, please. So what are some solutions to these issues? As I stated before, low-income areas tend to have a higher concentration of minorities in these researches, and they said that resources that these people are using, they're already familiar with and they trust them, so there's no reason to implement new resources that they may not trust. So going off of that, collaboration between government organizations and community organizations can be used instead of, starting from scratch and trying to implement new things, just using what's already in the community and is already trusted. Also targeting issues more directly instead of using more universal approaches. Obviously, if you give a whole bunch of resources, that's beneficial for multiple things, but it doesn't really target the issues that need to be targeted. And then changing the environments, targeting these disadvantaged neighborhoods and combating the environmental factors that are negatively affecting health, such as sedentary travel and poor housing conditions. If we target those, then research shows that, like, obviously there would be better outcomes for everyone living in there. Last slide, please. So just kind of to summarize, obviously, there's not one single factor that contributes to all of the health issues within a community. There's obviously quite a few, as I mentioned, but if we take the time to look at them, even just one of them at a time, and really target them, then we can create better communities that will hopefully have better health outcomes for everyone that lives there and everyone in general. Thank you.
Thank you, Kirsten. We can create better communities and work with them to live better in general. Thank you for that wonderful presentation. The next presenter, I'm privileged to present to you Jordan Jensock, a senior in biomedical sciences, whom I have had a privilege of working with since probably the first month of joining Marquette as a freshman. But now he has progressed and worked with Dr. John Manch in this fellowship and probably has greater news. We know that this fellowship connects people and people move to higher levels. Jordan, please, you're welcome to present to us.
Yes, thank you for that introduction. My name is Jordan Januziak, and I have been working under the mentorship of Dr. John Manch to perform my ongoing research project, which looks at the modifications available to the educational community in Milwaukee that can address the continued perpetuation of the cycle of trauma that is occurring and associated with the prevalence of structural racism and discrimination. So next slide. Starting big picture, I want to illustrate the prevalence of structural racism and discrimination, which can simply be defined as the policies and practices that perpetuate racial group inequities. Although this is a global health issue, there is a clear prevalence of this issue right here in Milwaukee, and even more specifically within the educational system we currently utilize. Included in the slide are some stats that have been associated with these disparities in the educational outcomes that are prevalent in Milwaukee. So the first graphic on the upper left illustrates one of the target demographics of this study, which are children currently in out-of-home care, which is a court-monitored process that coordinates placement and services for children and families due to accounts of abuse and neglect. Out of the 7,104 children that the out-of-home care had custody in Milwaukee's Child Protective Services, 33.9% were Black or African American, an overrepresentation of the 11.4% of the child population this demographic makes up. The sheer number of the children in out-of-home care illustrates the idea that there's a high prevalence of children who have experienced childhood trauma of some kind, with a disparity in the Black and African American population, hinting at a structural discrimination component as well. This leads to the next infographic, right to the right, which illustrates indicators of childhood trauma, or ACEs, here in Wisconsin. ACEs are adverse childhood experiences or traumatic events that occur before a child reaches the age of 18. They include types of abuse and neglect, such as parental substance abuse, incarceration, and domestic violence. ACEs have been directly correlated to poor health outcomes, and as you can see, adults in Wisconsin are disproportionately affected based on categories of race and ethnicity. The other two graphics highlight more focused educational disparities in Milwaukee. Studies have indicated that educators of color hold higher expectations for students of color, and their presence in their educational journey is strongly correlated with graduation and college enrollment rates. As you can see from the lower infographic, only 3.9% of teachers in Milwaukee are Latinx or Black, while the student population that is Latinx or Black stands at 21.4%. The last infographic highlights comparative school commitment within the academic staff in Milwaukee. A strong professional culture is imperative to improving Black student achievement, and 86% of schools serving white students had teachers more committed to their school than the typical school serving Black students. So I'm currently working with two research teams to facilitate my understanding of structural racism and discrimination. The first seeks to evaluate the impact, accessibility, and social structure has on the health outcomes related to opioid use and overdose in Milwaukee. And the other is currently working to explore how biomarkers and biological indicators of long-term stress caused by structural racism and discrimination affects health outcomes in Milwaukee. Both of these groups have been essential to my research process as they provide improved frameworks and methodologies of exploring structural racism and discrimination and provide institutional connections that are necessary for practical implementation of the findings. So even though the research is ongoing, the literature-based research in various groups and individual collaborations have begun to highlight 3 areas of meaningful intervention to address these issues and promote more equitable educational outcomes. And there are trauma-informed school-based interventions, teacher retention accommodations, and integrative classroom and district policies. The policy intervention areas that are currently being explored are as follows: ACE and trauma-informed individualized educational program procedures, mandatory out-of-home care trauma-informed school-based interventions, anti-segregation and pro-integration legislation for active integration of schools, and then educator and workplace discrimination education and training for school faculty. Here's the list of the current and anticipated collaborators working on this project. The organizations include the Medical College of Wisconsin, Marquette, UWM, the Social Development Commission, and the Department of Public Instruction. And then there's one more slide. And then these are just a couple of the literary sources that have been incorporated so far. And that's it. Thank you for your time.
Thank you, Jordan, for that wonderful presentation. Jordan never mentioned that he's soon entering graduate school. Congratulations upon that good news.
Yes, thank you.
Yeah, be reminded that each presenter will be spending 5 minutes. Let's continue with the rest of the presenters. Our next presenter is Michaela Amatio. She's majoring in medical laboratory science and is working with Dr. Nilanjan Lodi. We can call her Mickey. Mickey, the floor is yours.
Thank you. My name is Mickey Marcio. I'm a junior majoring in medical laboratory science, and I've been working with Dr. Lode this semester and year on the determination of health and well-being of African American community in Milwaukee's North Side via assessment of telehealth. So the objective that we wanted to address was the need and disparities of telehealth usage in the North Side African American communities of the Milwaukee area, along with the collaboration of community partners. So, and these partners include the Bread of Healing Clinic, the Walnut Way Conservation Corporation, several local churches, and other Marquette University affiliates. Some of the methods that we decided to use, we first did community forums. So we hosted 2 community forums in a local high school in the Milwaukee area where we introduced the study, we introduced our partners to the community. We made sure to involve the community members, be able to get their feedback, have them take a survey, be able to address some concerns and have discussion groups about our research. We also did an analysis of data. So the main things that we wanted to focus on was health history, of course, with asthma, diabetes, and COPD, and hypertension. But we also looked at age and gender and heritage. And we'll be diving deeper into that. We also did, or are going to do, a pilot study, which involves 40 members of the community in partnership with our local partners and the churches and the community in there, where we will be giving Fitbit and glucose monitors. Next slide. So for the pilot study, we will be using Fitbit and glucose monitors for this study. And then some of the data, the results that I analyzed, this was just difference in age groups for prevalence of diabetes, hypertension, and asthma. And so the bottom right-hand corner is the all yes group. So all yes to they had hypertension, diabetes, and asthma. The biggest group here includes the 61 to 70-year-old group. The second biggest is the 36 to 45-year-old group, which is slightly surprising. And then the next slide. The Eastbrook data that I also analyzed, this is the same format, just another data set. So the biggest group here in the bottom right-hand corner is the 51 to 60-year-old group, and then the second is the 36 to 45-year-old group, similar to the last one. Thanks. So the next steps that we want to continue to do is we want to keep working with the community, especially the Lindsay Heights community that we've been involved with. We want to keep working with our partners, so Walnut Way, Bird of Healing Clinic, want to open our opportunities even wider, continue more research work. We are going to do another community forum that will be virtual in the summer, and then we are also doing the pilot study as well, which will take place over the next year or so. And some acknowledgements was for the other fellows involved in this project, the local churches, Bird of Healing Clinic, Walnut Way, and then the President's Challenge Board. Thank you.
Thank you, Mickey, for that good presentation and for the community engagement. Thank you, Dr. Lodi, for that guidance that you've worked with Mickey. Our next presenter is Hannah Barbosa. I hope I pronounced it excellently. She is majoring in nursing, and she has a minor in Spanish for health professions. And she's been working with Dr. Linda Pearson, investigating quite a lot of work among COVID survivors, plus some other additional work. So please, Hannah, the floor is yours.
Thank you, Dr. B. So like Dr. B said, my name is Hannah Barbosa, and I've been working with Dr. Linda Piacentine and really a big group of people on the COVID-19 research study that's going on Marquette's campus at the HPRC. I had more of my focus on the qualitative portion of that study, and my research really focused it on interpersonal relationships and the COVID-19 pandemic. Thank you. Entering into the pandemic and everything, I'm sure we all had a lot of changes. And one thing that I saw a lot was changes in relationships people had with each other. So my research question was really focused on what those changes were in these groups of people who had COVID, who were COVID survivors. And then the purpose of the study was, the research was to describe perceptions and the changes of those relationships for those people infected with COVID. So how it worked was we had a total of 35 COVID survivors who we interviewed at the HPRC on Marquette's campus. And these interviews were in person, and we kind of had a research or a question guide that we would use to guide the conversation, and really what these people were saying kind of led us to different avenues and different topics of discussion. We recorded those interviews, we put them into a system that transcribed them, we reviewed them and checked them for accuracy to make sure what was transcribed matched with what people said. And then there was a group of us who went through and analyzed, pulling out common themes between the different interviews we had. If you go to the next slide, thank you. So from that, we had 4 main themes that we pulled out, and the one that I really focused on was those impacts on interpersonal relationships. So interpersonal relationships was kind of the bigger theme, and then we found different sub-themes within that. One of them was isolation. So I'm sure we all experience really limited in-person social interactions, not only when these people in the study were positive with COVID, but also just throughout the entirety of the pandemic. And this was mainly viewed as a negative impact for people. Another thing in relation to the isolation was that people spent more time at home with their families, and this could really go either way. People saw it as beneficial, where they grew closer with their families, they enjoyed spending time at home, or there were others who didn't really maybe get along with their family as well. Their family and them had different opinions, and that isolation at home with them was viewed more as a negative thing. A second sub-theme we pulled out was work and school-related stress. So really the loss of balance and defined boundaries between work and school and home, because we were all now switching to online meetings, online classes. There was not really any transition time, like your 15-minute walk to class or your drive into work. It was just log on to the computer and then you just were in meetings or classes back to back to back. So that added to a lot of stress to people's days and work and school life. And then the third sub-theme was social support systems. So kind of mentioned above already, but people really found support within their household. And we had a lot of people say that they feel like they've never been closer to their kids or to their parents, and they saw that as really positive and beneficial thing. Something we also kind of teased out from the research was differences between men and women. And one thing mentioned was that women found that they had more disrupted friend and extended family relationships due to differing opinions on safety measures. So it was their families were still maybe having parties that they did not feel comfortable going to. They felt like they couldn't talk to their families about things. And also that added a lot of stress to their life too, for fear of safety of themselves, their families, their extended families. And that was kind of the summary of those interpersonal relationship impacts we heard in the interviews. So what do we do with that? Kind of how are we informed from that research? The pandemic obviously altered relationships and our way of connecting with others. And from that, I think what we need is more mental health assessments and interventions to address those feelings of stress that were mentioned, as well as a greater balance between in-person and online relationships also coming from that. And then the last slide is just a big thank you to everyone on this study. As I mentioned, the qualitative portion was a part of a bigger study and a big group of amazing people who are all working to study COVID-19. So thank you.
Yeah, thank you, Hannah. The four were great presentations. I'm talking of HPRC. We have Dr. Sandra Hunter, who's going to be moderating for the next three presenters, and she's the director of the Athletic and Human Performance Research. Thank you. Dr. Hunter, the floor is yours.
Thank you, Dr. B. All right, thank you. So I'm introducing the next three speakers, and the first cab off the rank will be another student from Dr. Linda Piacentine, Tara Naylan, who is who's a student in the Bachelor of Science in Nursing program. She's also in the Public Health and Equity minor, and she's also an Evans Scholar, and she's going to be talking about intimate partner violence screening. Thank you, Tara.
Hi, everyone, and thank you, Dr. Hunter, for the introduction. As she mentioned, I'm a junior in the College of Nursing, and the project I'm presenting to you today is about intimate partner violence screening. Next slide, please. So before we get into it, I want to introduce my wonderful team that I've had the opportunity to work with since September. Dr. Linda Piacentine, who is my mentor for the fellowship, Dr. Dropke Owen, who was a past professor of mine, and Alyssa Field, who's the nursing school's go-to gal for helping find research articles. Next slide, please. So a lot of you are probably wondering, what is intimate partner violence? Intimate partner violence is abuse or aggression that occurs in a romantic relationship. Intimate partner refers to both current and former spouses and dating partners. IPV can vary in how often it happens and how severe it is. It can range from one episode of violence that can have lasting impacts to chronic and severe episodes over multiple years. So IPV can include any of the following types of behavior. There's physical or sexual violence, psychological aggression, and stalking. So IPV is way too common. About 1 in 4 women and nearly 1 in 10 men have experienced physical or sexual violence over the past few years in their lifetime. So IPV is a preventable public health problem, which has worsened with the isolation at home during the COVID-19 pandemic. If you could click, please. So as you can see, our overall study focus is to improve IPV screening and referral for services in primary health care settings. Next slide, please. So although IPV is a health concern with a lifetime prevalence of 40% among women, it is not often really discussed in provider visits. So this leads us to our research question of how we improve primary healthcare recognition and referral to those that face intimate partner violence. So our aim of the study is to develop and implement system changes related to IPV awareness and screening, and along with referral placement within hospital system clinics. This is going to be done in two ways: integrating the exercise of an on-site advocate along with training the clinical staff to improve screening and referral for possible IPV survivors. So lastly, we want to learn ourselves. Lastly, we want to educate ourselves further to gain a better understanding as what practices are currently in place in the primary healthcare setting, so we can generate enhanced screening practices that will be used statewide. Okay, next slide, please. So we used a web tool called Rayon to help conduct our literature search. This tool helped us to speed up the process of screening and selecting studies we will use with the rest of our scoping review. As you can see, we have selected 130 articles out of our 1,532 to include in our scoping review. We will then review those and select what we will use in our final review. It's a really tedious project, but this is how we gain the best insight needed for our project. Okay, next slide, please. So what you're looking at now is the Rayon, which is the main database that we used to conduct a literature review. So as you can see, some of the articles on the screen are, we went through them, all 1,500. So after reading them, we had to collaborate and vote on which articles we will include in our literature. So the ones in green are the ones we are including, and the ones in red we are excluding. We got together to discuss the ones we had differences on, and we talked about it until we came across a consensus. So yeah, that's a sneak peek at the wonderful resource we have. Next slide, please. So for our abstract search outcome, we're doing a scoping review of the literature. So as mentioned in the previous slide, we have 130 full text articles that we will continue to review so we can use some of the information found in our overall scoping review. It's a super important step in our overall goal because scoping reviews help us to identify and map the current evidence along with recognizing knowledge gaps that primary care clinics have for IPV screening. So this data is necessary to identify the current practices in place so our team can work to improve them. So another important goal for us is to become better community engagement partners with the clinic sites around us. Next slide, please. So I don't have a conclusion or a summary of our study yet because this is just the beginning of the work we'll be doing over the next 2 years. So the next step moving forward will include beginning focus groups at our partner clinics such as Sojourner Family Peace Center. This will help with the data collection so we can begin designing implementations needed. Our public health objective is to participate in developing recommendations for both system and policy changes statewide on screening practices for intimate partner violence and primary healthcare clinics. So this is a huge project. We definitely couldn't have done it without our other partners too, such as IWL, which is the Institute for Women's Leadership here at Marquette, CTSI, and they are the Clinical and Translational Science Institute for Southeastern Wisconsin, along with Advancing a Healthier Wisconsin Endowment, and of course, with the help of the College of Nursing. So that's all I have for you guys today. Thank you for your time.
Excellent. Thanks so much, Tara. That was very informative. Thank you so much. All right, so next we have our third nursing student, but a master's student, and that is Alexis Roofie. Sorry if I mispronounced that. Maybe Ruffy. Who is mentored by Dr. Kim Whitmore. Thank you, Alexis. She's going to be talking about understanding the respite care experience of Latinx families of children with special healthcare needs. Thank you.
Hi, thank you so much. I'm Alexis Roofie. Yeah, I'm a direct entry MSN student, the College of Nursing, and I'm working with my mentor, Kim Whitmore, to understand the respite care experience of Latinx families of children with special healthcare needs. And then some of our other team members on board, Katie Baeza, Monique Radoche, and Hector Portillo. And so next slide, please. And so just a little bit of a background. Children with special health care needs include those who have or are at an increased risk for a chronic physical, developmental, behavioral, or emotional condition, and who also require health and related services of a type or amount beyond that required by children generally. And so what respite care seeks to do is it looks to provide a break from caregiving responsibilities. Specifically, it can improve caregiver and family outcomes, and it doesn't take one form. It's very diverse in how it can be carried out, such as by family or government or community agencies. And so what we do know now is that respite needs are largely unmet for Latinx families. They have 2 times unmet needs in comparison to non-Hispanic white families. And there's cultural and linguistic barriers in place that we want to further seek out. There's a gap in resources for racial and ethnic minorities for respite care. And so overall, we're just looking to better understand culturally and linguistic appropriate interventions that we can put into place for this community. Next slide, please. And so what our project is seeking to do, it's a community-based study that has both quantitative and qualitative components. And so first is the option of enrolling to complete an online survey. And so I think in the next slide kind of go into what that entails. And then from there, once the families complete that survey, they have the option to say if they would like to engage in a interview. And so that's a one-on-one and semi-structured. And those are conducted virtually or in person, and English or Spanish based on their preference. And specifically to reach this community, we're partnering with a nonprofit based in Dane County, Padres de Hijos en Acción. And it's a nonprofit dedicated to supporting Latinx families of children with special health care needs. And so working closely with this organization, with Hector Portillo at there, we can better understand how we can tailor our project to best support the families with culturally relevant questions and better interpreting the results. And so, yeah, next slide, please. And so our findings were very early in the study, so our project is still ongoing. We are still in the process of collecting our data, and some of the forms of data that we're looking to collect on, specifically first with the survey, we're going to have demographic information that we'll be asking about. We're going to have the global family quality of life scale in there, family APGAR, and perceived stress scale, so we can better understand stress and quality of life of the families as well. And then we're going to be doing the interviews, like I said, with the Latinx parents or guardians of these children, and better understand the impact respite care could have on them, what facilitators or barriers they see to getting quality respite care, so that they can have improved family and caregiver interventions or outcomes. So yeah, next slide. And so just anticipated results that we hope come from this study. We want to better describe the experience of Latinx parents caring for children with special health care needs. Through the interviews and the survey, we hope to determine facilitators and barriers of Latinx parents' use of respite care services. And then in collaborating with Padres de Hijos en Acción, we want to develop culturally and linguistically appropriate respite care interventions that ultimately seek to improve family and caregiver outcomes for these families. And so we want to get these findings, but then also give back to the community that is so gracious to share the information with us. And finally, going beyond this individual level, we want to share findings to inform recommendations for funding and public policy at the state and national level. So spread our findings there. Next slide. And so thank you again to Padres y Hijos en Acción for working with this on this project. If you would like to find out more about their work, I put the link there. Thank you to my mentor for giving me opportunity to be part of this fellowship. Thank you to Dr. Lode for facilitating all the meetings and everything. And yeah, thank you so much.
Thanks so much, Alexis. That was fantastic. All right, our last speaker, and I'm just so impressed that everyone's staying on time. This is great. Our last speaker is Zach Farahani, who's in the Bachelor of Science in Computer Sciences, and his mentor is Dr. Praveen Madiraju. So take the floor, Zach.
Thank you. Thank you. So my name is Zach. I'm a data science student at Marquette, and my project is a comparison of oversampling techniques for predicting length of stay. And my mentor is Dr. Praveen Madiraju. So yeah, that'll take us to the next slide. So the problem that I'm trying to solve essentially is how can we effectively predict a patient's length of stay so that their treatment plan upon entering a hospital might be more holistic. I'm using a quantitative model called deep learning, which is a cutting-edge subfield of artificial intelligence. This problem has been attempted before, but I'm conducting novel oversampling techniques on the dataset, and I'll get into what that means. The dataset which I'm using for this project is a collection of patient records, which has been compiled into comprehensive information on each patient. This dataset has been anonymized for the safety and privacy of the patients. Next slide, please. That's the one. So as I mentioned, the main method I'm using to predict the patient's length of stay is deep learning. Deep learning is an algorithm used to predict a target, in my case, length of stay, based on other information. The inspiration for deep learning is based on research that was going on in the 80s about the structure of the brain. The idea is that you input information into the model, and then each neuron can decide whether or not to fire based on the information you give it. And the firing of the neurons then flows downstream to the next layer of neurons until you reach the final layer of the model where the prediction is made. As a visual on the right, we can see that there's a deep learning model where each pixel of a picture is used to try and predict the number that is being shown. This technology is being used in insurance, computer vision, autonomous vehicles, and in finance and investing. Next slide, please. So on the right here, I have another visual, which is a deep learning model that is learning how to model this complex spiral relation. I chose this visualization because it shows the importance of what's called hyperparameters. You can see these little buttons, number of layers and number of neurons, and also these statistics on the top. These are called a hyperparameter, and they're effectively how you choose to set up your model before you run it. As we can see on the right, it is learning well, but given bad hyperparameters like a small amount of layers and neurons, it will learn nothing. As a part of my project, I'm using a novel hyperparameter selection method called Hyperband, and Hyperband is a cutting-edge hyperparameter selection method. Next slide, please. So now that I've told you about the algorithm I'll be using, I want to talk about the novel part of the project. A unique part of my project is using a technique called oversampling. But first, I have a small demonstration. All the faces that you're seeing, they're all actually fake. These aren't real people, so they're all generated from a deep learning algorithm. So essentially what oversampling is when you have data and you artificially create more of it. In my research, this fake data is used to help predict people's hospital length of stay. So I apply the same concept of a deep learning algorithm, except some of the information I feed into it is about people who do not exist. And this turns out to enhance the predictive power. Next slide, please. So now you know about the research processes, and I can tell you a little bit about how it's going. So the best iterations of deep learning models that I've come across have been about 90% accuracy in determining the patient's length of stay. We're having a lot of success with oversampling techniques that we're using because they allow us to come up with more underrepresented instances So for instance, if we do not have a lot of information about a certain type of person, we can generate more, and this happens to help underrepresented instances within the data set. Next slide, please. So as a summary, we give a big overview of deep learning, what are hyperparameters, what is oversampling. And now essentially it's my job to compile all this listed information into a paper, which I plan to publish the results. Next slide. Yeah, so, thank you. So thank you to Dr. Lowe, Dr. Praveen, the PDHE program, and to the President's Challenge Funding Program. Thank you.
Zach, that was excellent. Thank you so much. I got to say, I swear I saw someone I knew on that photo, on those pictures. They couldn't be fake. That was my friend. All right, well, thank you so much. That was I think that was an excellent example of translational team science here, how we can take computer science to help solve real world problems within healthcare systems. So thanks so much. That was excellent. All right, well, that comes to the end of our student talks. What a vast breadth of projects, and just a real wealth of experiences there, and knowledge, and depth of experiences. Thanks so much for your dedication, students. And now we're going to, in the last 5 minutes, we're inviting Dr. John Su, who's Senior Vice Provost for Academic Affairs and Student Success at Marquette, to say a few words. Thank you, John.
Thank you, Dr. Hunter. And, to our 11 fellows, I'm just so tremendously impressed by the work you're doing. You all are inspiring. It's what we hope to be engaged in as a Catholic Jesuit institution. So thank you for the work you're doing. Also want to express gratitude to our faculty mentors for helping to build and sustain this remarkable community. And most especially, gratitude to Dr. Bionanabaye and Dr. Lowe for envisioning this program and organizing it for us this year. Thank you for really helping to bring our community together, particularly at a time when we're all looking for these moments to connect. So thank you.
All right, I think we're ending there. Dr. Lowe, did you want to have any parting words?
I think I just like to thank all the fellows for their great work, and I think hopefully some of them will continue their work in the future. And I'd like to thank all the mentors and all our supporters, IWL, HPRC, College of Nursing, and College of Health Sciences, College of Arts and Sciences, and Dr. Jean Hosenloop's office, Dr. John Su, all the administrators, and definitely the families and friends and whoever is on the call who actually dedicated their time and kind of supported the fellows throughout the program. Hopefully we'll be able to continue this program again in the future. So with that being said, have a good rest of the night, and the finals week is here. So good luck to all the fellows for your finals, and have a good rest of the semester. Thank you.
Thank you, Neil. Thank you, Dr. Su. And thank you, parents, supporters, and everyone else, and obviously students. Signing off.
Thanks, everyone.